Anybody? Nobody? Um, with drips, you have to practice them. I can't. You have to get, and this is all through paramedic school. Sitting through lecture isn't going to teach you everything. You're going to have to go through and talk to people or talk with other students that are in the class as well to learn things. And also getting feedback is pretty important to me. So, knowing if there's something you guys need a little bit of work on or something like that. I'm going to pull up the drip sheet that I put up yesterday because it's a little bit easier in regards to just kind of getting into drips for me to explain as opposed to some of these harder ones. So I'm going to pull that one up and then we'll go through a couple of those and hopefully they make a little bit of sense. All right, everybody able to see my screen? See the first problem on here?
Yes.
Okay, perfect.
Yep.
I'm hoping this records. I changed some settings. If not, I am going to upload my sheet that I did the problems on to Canvas as well, just so answers. And I did long drawn out processes, so it makes a little bit more sense. I did it step by step. And that's going to kind of what I'm going to do here. So I showed you guys like this big, long, horrible thing when it comes to using a clock and trying to figure out drips. So let's just look at question one here. If you can figure out question one, you can probably figure out the rest of these questions. It's asking us that we're being ordered to administer 10 micrograms per kilogram per minute to a 220-pound patient. Okay, well, I already see a problem because this is asking for kilograms and it's supplied in pounds. So what is this? How do we convert pounds to kilograms?
Divide by 2.2.
Okay, divide by 2.2. Let me see if I can change the thickness of this. Okay, so let's do 220 divided by 2.2. And I'll be honest, I have to use a calculator for this. Even the students that I've had that took their national registry recently, there was no like crazy math to where they couldn't figure it out in their head. Now, the ones I'm giving you are hard. They're tough, and I'm doing that for a reason. And it's so that when easy ones come along, they're really simple for you to figure out. So 220 divided by 2.2 gives me how many kilograms?
100.
Okay, so I've got 100 kilograms. Okay, so that's a vital piece of the puzzle. I always circle everything. 100, if I didn't mess that up. 100 kilograms. Now, it's going to ask, we need to administer 10 micrograms per kilogram per minute. So I need to do 10 micrograms per 80, or sorry, God, 80. That's supposed to be 100 per 100 kilograms.
Rudy, are we supposed to be seeing something that you're writing right now?
Can you not see me writing?
I don't think so, unless it's just me.
No, I can't see anything either.
Oh, lovely.
I can.
Hold on, let me.
I don't know.
You can or can't?
I can. I'm on my phone. Oh no.
I cannot.
Okay.
Can't.
That's insane. 1 second here to get it all figured out. You guys can still see, right? The screen.
Yep.
I can see.
Yep.
So when I go to write on this, you can't see.
I can
You
see
can't
your
see-
mouse moving.
You can't see the red.
No.
No.
I don't know why that's doing that. All right, so let's. Crap.
I can see you drawing for some reason.
You can.
Yes.
I still can too. I don't know.
Are the
Maybe it's
rest
because
of-
I'm viewing in browser that I can't see it. I don't know.
That might be what it is.
Yeah, I'm on the computer too, so I can't see it.
Okay. But you can see the problem though, right? Like, you
Correct. I can see your screen in the
okay,
Word document.
okay. As long as you can see the problem, I can work with that. Okay, so we see 10. Okay, so somebody else can draw. You guys can all draw on here because I just saw somebody else draw. So we agree that this patient weighs 100 kilos, and we agree that the dose ordered is 10 per kilo per minute, right? Just based off the equation they're giving
Yes.
us. Okay. So 10 times 100 kilos equals what?
Thousand.
Okay.
1,000.
So 10 times 100 kilos equals 1,000. So I know that 1,000 is how many micrograms I need to give to this patient per minute. Now, I generally would use a clock, and this is where some people don't. The other thing we need to figure out, we know the weight, we know how much we need to give based on the weight. We need to figure out the concentration of the medication. It's pretty simple. It says it right there. So what's our concentration?
16
Yeah, 1,600. Yep, you're right. So
micro.
yep, and that's always, your concentration is always going to be how much parts of drug are in 1 ml. That's always going to be your concentration. Now, instead of doing the clock, what you can do is take that 10 micrograms per kilogram times 100, so the weight in kilograms, times 60, because we're using a 60 drop set. And that's told to us in the problem itself. So if you have a calculator on you, everybody should have a calculator.
So that would be 1,000 times 60.
Yeah, yep, it'd be 1,000 times 60. Gives me what?
60,000.
Okay. So then I take that 60,000 and divide it by my concentration. So 1,600. What is that? What do you get from that?
37.5.
So the answer is 37.5 drops a minute without using a clock. That's the easy, quick way to do it.
Wait,
Is
what did you
you
divide it by? I'm sorry.
The concentration. So 1,600.
1,600.
So if the concentration was 800, I'd divide it by 800. If it was 1,400, I'd divide by 1,400. I'm doing the 10 because that's what's ordered, 10 micrograms per kilogram per minute. Well, I know there's 100 kilograms, so 10 times 100 is 1,000. I multiply by 60 because it says I have a 60 drop set. And then I divide by the concentration, and that gives me drops per minute.
Can you tell me what the concentration is again? You said concentration is always what?
It's always going to be how many parts are in 1 ml of fluid. How many parts of medication are in 1 ml. So if I look at that picture right there, it says there's 1,600 micrograms in 1 ml. There's a difference between medication and fluid. Fluid is just a vessel, as to where the medication is what's going to be doing the job of whatever we're wanting it to. So there's always going to be medication, and then there's always going to be fluid. But your concentration, when I say concentration, it's how many parts are in that 1 ml. So if I said I have 150 milligrams in 3 ml. What would my concentration be per one then?
50.
Yeah, that's my
50.
concentration. Yeah, that's all we're figuring out. That's when I say concentration, that's all we're figuring out. We're bringing it down to per ml. And it could be a bag of fluid, it could be anything. So if I have a bag of fluid, let's just say it's a 1,000 ml bag of fluid, and that 1,000 ml bag has, let's say 250 milligrams in it. How do I figure that out? For one, I
Okay,
need to,
before,
okay,
you just divide it by 4?
yeah, well, it'd be 250 divided by 1,000, which gives you 0.25.
Okay.
Because there's 250 parts in 1,000 milliliters. So that would mean there's 0.25 milligrams in each ml. So if I did 0.25 times 1,000, it would give me that 250 again.
Okay. I'm sorry to waste your guys' time, but I switched to my phone and I wasn't hearing you. Could we go over this problem one more time?
Yeah. So actually, let's pick a different one because I've got a couple other ones on here as well. So let me go to the second one,
Okay, thank you.
and it's the same medication. So okay. So everybody should be able to see problem 2. It's asking us to give how much medication?
$1,600.
No.
Five
What?
5 mics per
micrograms
kilo.
Okay, so it's asking me, it says literally you're ordered to administer 5 micrograms per kilogram. So I need to figure out how many kilograms my patient weighs. The weight is 180 in pounds. So I take 180, divide by 2.2, because that's how we figure out kilograms. That gives me 81.8. I don't like decimals, so I'm just going to say 82. So patient weighs 82 kilos. So I would do 5 micrograms times 82 kilos. And it says you are using a micro drip set. Micro drip sets are always 60 drops a minute. Always. If you look at the package of a 60 drop set, it says micro on it. So my equation would be 5 times 82 times 60 divided by my concentration. Looking at that bag, what is my concentration?
That's 1,600.
Okay. So I've got 5 times 82, 5 times 82 times 60 equals 24,600 divided by 1,600 equals 15.3 drops a minute. Let me see if I can, if I pull up Teams, let me see if you guys can see a whiteboard. If I stop presenting, that might help a little bit. All right, can you guys see if I draw up here in the right hand corner, can you see that?
Yeah.
Okay, perfect. So in that last equation, I'm just gonna draw pretend bag of fluid. It said our concentration was 1,600 micrograms per ml. It said we had to had to administer 5 micrograms per kilogram per minute to our 220 pound patient, or not 220. Let's use 220 though.
Okay.
So what's 220 in kilograms?
100.
Okay. 100.
2.2 divided by or 220 divided by 2.2 is technically 100. If you do the 10% thing, it gets you at 90. So let's just say 100 kilograms. So if I look at this right here, literally I have to just plug that number in. So that becomes 5 micrograms, 100 kilograms per minute. Okay. Well, I know that we're using a 60 drop set because it said, so we're going to put 60 where minutes is, because a 60 drop set drops 60 drops in a minute, but that 60 drops also equals 1 ml. So this now becomes 5 times 100 times 60. You just put whatever the drip set is, divided by 1600. That's literally all the equation is. And that will give me how many drops per minute. So let me pull out my calculator because, again, I'm not superhuman. That's 5 times 100 times 60 is 30,000. Divided by 1600 equals 18.75. GTTS just means drops per minute. That's the easiest way there is to figure out a drip rate per minute. If it's a medicated drip, if they're asking for a weight based, that's the easiest way right there.
So, a question. So let's say we change it. We're not using dopamine. So if we put it on a clock method, do we still? Say it's a concentration of 400. Do the same thing then on the clock, right? The 12 o'clock is 400.
Yep.
3 o'clock's 100. 6 o'clock's 200.
Yep.
Okay.
But if you do it this way, you don't have to, for some people, the clock doesn't click. So this is a way to bypass the clock, is just do this simple equation. Now, let's look at number 3 real quick. See if I can. Let me see if I can draw it out for you guys. Okay, number 3 says you are ordered to administer 4 micrograms per kilogram minute to your patient. Doesn't give you on that sheet, it doesn't give you a patient weight. We're just going to use 220 pounds. For some reason, I forgot to put the weight when I was typing it. That's my bad. It says we're using a micro drip set. How many drops is micro drips?
60.
60.
Okay.
60 per minute.
Okay, so 60 drops a minute. Okay, you see how like this here says minute and this here says minute? That's where I get the 60 from when you plug it into the equation. Okay, so using the micro drip set, we're going to administer 4 micrograms per kilogram per minute to a 220 pound patient. That's pretty easy. That equals 100 kilos. How many drops will be needed to accomplish this? Well, we need to know the medication. So it is lidocaine. There are 2 grams in the bag, but it also says that there are 4 milligrams per ml. Okay, we're ordered in micrograms, but we're ordered in micrograms, but we have milligrams that is supplied. Can you guys see the whiteboard? Can everybody else see the whiteboard?
Yes.
Okay. Yep. So if I need to convert 4 milligrams to micrograms, how do I do that? Micrograms are a lot smaller than milligrams, so there's gonna be more of them. So if I was going to convert 4 milligrams to micrograms, all I do is take the 4 and I move 3 decimal spots to the right. So 1, 2, 3. I fill in the areas I move with zeros. And that's how many micrograms I have now. So 4 milligrams equals 4,000 micrograms. So my concentration is either 4 milligrams or an ml or 4,000 micrograms in ml. So let's plug this in now, the whole equation. 4 micrograms times patient weight times 60, because that's the drip set. Our concentration is 4,000 per ml. That's 24,000 divided by 4,000 equals 6 drops a minute. If I was to put that in a clock, I'd get the same thing or pretty close to it. Because the clock, you're kind of guesstimating as to where this is exact math. Now, and this freaks everybody out because they're like, well, with drips, if you're not exact, how do you answer the when it comes to time to take a test, how do you answer the question exactly? They will not, unless you are using a pump, you cannot guess the exact amount. I mean, it is a guess at that point. So anytime there's going to be a test question, it could be, let's just use this problem for example. It could say, okay, are you going to administer 50 drops a minute? Are you going to administer 14 drops a minute? 25 or 6? They're not going to be like, is it 6, 7, 8, or 9? Because there's that much room to change. Because 1 to 2 drops in the minute isn't going to alter what I'm delivering to my patient. It's not going to change considerably. It would have to either double or triple to when I would start to see a change in my patient.
So we just need to do the dose of the medication on the bag, and we don't have to worry about, because down on the bottom of that bag it says 500 ml. So that's just nothing, right?
Well, that's how much fluid you have for the whole bag. So
Right.
I mean, it says there's 2 grams per 500 mLs for lidocaine. So if I took 2 grams, let me draw that out real quick. And it doesn't matter what med it is, so I'm not going to put a medication name. And I'm ordered to give, let's go back to that 5 micrograms per kilogram per minute. If it didn't tell you the concentration on the bag, it's pretty easy to figure out. So right now I've got 2 grams in 500 mLs. Well, I'm ordered in micrograms. So this isn't going to work because it's not the same unit of measurement. So if I want to convert grams to milligrams, which is the next smaller one, I would take my 2 and I'd move it over 3 spots.
So there'll just be 2,000.
Yep. Now, to convert that even further to micrograms, I would just add 3 more spots. So it becomes 2 million. So that would become 2 million micrograms in 500 mLs. So 2 million divided by 500 equals 4,000 micrograms in ml, which is literally what we just did, or 4 milligrams. But you have to change it to whatever you're being ordered to administer your medication in. If you're going from a gram is the largest, milligram is lower, microgram is the smallest. If you're going from gram to milligram, you move 3 spots. Milligram to microgram, 3 spots. So if you're going gram to microgram, you just move 6 spots. Now, on the other hand, if I took that 2 million and want to convert it to milligrams, I would just go 3 spots in the other direction. So I would literally erase 3 zeros. It becomes 2,000. Now I have 2,000 milligrams. I erase 3 more spots. Now I have 2 grams. So 2 grams equals 2,000 milligrams, which equals 2 million micrograms. It's literally just three zeros, 3 decimal spots that I'm moving. I'm not good with decimals, so I have to literally draw the loops at the bottom and fill them in with zeros. It doesn't matter what the med is, the math is the same. I don't care what medication it is. We'll do one more here.
Rudy, I don't recall you teaching us this on a clock. Where did I miss that at? Where can I find that?
Was it 2 lectures ago? So I found out that when I record, you guys can't see the whiteboard in the recording if you watch it later. But what I just realized is when I click this home screen, it shows me all those old ones. So I will post those all tonight as well. Now, I'd discourage you from wanting to learn the clock at this point, to be honest, because it's gonna trip you up more than anything. But I will happily show you. So let's look at number 5. 5 says you need to administer 5 micrograms per kilogram per minute to a 300-pound patient using a micro drip set. Micro equals 60 drops a minute. Okay, first thing I got to do is convert pounds to kilograms. So 300 divided by 2.2 equals 136. The medication we're using is dopamine. Dopamine will always be 1,600 micrograms per ml, always. So I take my 5 micrograms times my patient's weight times my drip set divided by my concentration. 5 times 136 times 60 equals 40,800 divided by 1,600. Oh, I just fat fingered the calculator.
25.5.
Yeah, so that's your answer. Equals 25.5 drops a minute. Is anybody, people can still see my screen, right?
I cannot see.
I can.
I don't know if maybe if maybe you're watching on a phone, or I'm not 100% sure on why people can't see it, or you're not using the Teams app, or I guess I'm not, I guess I've never had this issue, so I might have to get IT involved to see why nobody can see it, why some people can't see it and some can.
You're still on the whiteboard, right?
Yes.
Yeah,
Yeah.
I can. Okay, I can see it.
On my computer, sometimes I have to zoom out so that I can see all of what you're doing. If you
Okay.
add more to it, but that's about it. I can still see it.
Okay.
Oh yeah, same.
Now, but I guess it's kind of counterintuitive for me to show the clock if not everybody can see the clock. It's not going to make much sense because you really need to see before I can try to show it to you. There's the clock method. There's this method. I would pick one of these. Now, again, some people did not get the clock at all, but they were like, well, this is simple. It's just literally plugging numbers in and using, trying to figure out what it is from there. That's literally all it is. There's nothing more to it. Remember, if you want to figure out fluid over time, which is just, I want to, give 1,000 mLs over an hour. All I'm doing is taking 1,000 over the time in minutes, so 60 times whatever drip set. So maybe I'm using a 60 drop set. So I'm going to run it at 1,000 drops per minute. That's how you figure out fluid over time, not medicated fluid. But that doesn't change if, say, you have a question that says they want you to administer a 500 ml bag of epinephrine over an hour. They're not asking you for a specific dose. They're asking you how much fluid you give over that time. So if they're asking fluid over time, then you do that equation. If they're asking drops per minute for like a medication, like a dose like this, then you do this equation. A lot of times with drips, people kind of tend to overthink it and make it harder than what it is. I'd say that's actually what I ran into with a couple people who have asked me questions about it, is they're kind of overthinking it just slightly, and so it makes it worse for them. As far as I'm not sure why I can't get the whiteboard shared to some people. Honestly, I'm not 100% sure. But I will post these tonight so you can see them, and it'll have the recording attached to it.
So I figured out what's wrong. So on the bottom, we can see little dots of everybody's name. At the very end, there's an option where you can push it to see the screen, or you have to push it to see the whiteboard on the computer.
So you can see the whiteboard now?
Yes, but you
Okay.
have to push that option in the right-hand corner.
Okay, awesome. Thank you.
Yep.
Now, okay, so since you can see that, or you can see this, you can see that our answer is 25.5 drops a minute that I'm circling here.
Yes.
Okay. I'm gonna plug that. I'm gonna take this information and put it into the clock.
So my school barely had a foreign language class, so we didn't have anything like that.
Right. I think I can do it from like classes from 6 a.m. 8 or something. That way the high school kids.
Hey Matt, you want to mute yourself?
Period to go to.
There we go. All right, so that same equation, 5 micrograms per kilogram per minute. Patient weighs 300 pounds. So I think, what did we say that was? 136 kilos. I know the concentration is going to be 1,600 because it's dopamine. It says it right on the bag. 1,600 micrograms per ml. So now this is very similar. So I'm going to take that 5 micrograms times 136, which will give me, let me see. Gives me 680. So 5 micrograms times 136 kilograms equals 680. micrograms. That's how much I need to administer. So now what I'll do is what it says we're using a micro drip set, right? So how many drops are in micro drip? I know I've asked that a ton of times. I'm gonna keep asking it.
60.
60. Okay. So at the top goes 60 because that's how many drops equal an ml. We're using a 60 drop set. 30 is half of 60. 15 is half of 30. 15 plus 30 is 45. So that's just referring to drops. On the outside of the clock is going to go 1600 because 1600 also equals an ml, along with 60 drops equals an ml because we're using that drop set. 1600 I'll cut in half. 800 I'll cut that in half yet further. 400 plus 800 gives me 1200. We know the answer from the last equation was 25.5 drops a minute. So let's see if we can kind of match that up with this. I know that I need to give 680. So that's going to fall in between 400 and 800. So if I had to say probably right here. So I'm guessing that's pretty close, 25.5 drops a minute. That's the clock method. Some people don't like it. Some people do. There's more steps involved as opposed to just doing your simple equation. Does that make sense? I mean, I don't want to. I want to make sure that I'm answering any questions that somebody has at this time seriously. And I don't. It's not going to make 100% sense. As long as you can just know the equation and plug the numbers in, that's what I'm looking for. Perfect. All right. What we're gonna
Rudy,
do?
sorry, quick question.
Yeah. Go ahead.
You were talking about fluid over time, and then what was the other rate that or the other problem we were figuring out?
What do you mean?
So fluid over time is like what like the first questions we worked through we're figuring out, correct?
Yep. So that's just if
the other. Go ahead.
That's just if I say give 1,000. You're ordered to give 1,000 mLs an hour. How many drops per minute are you going to run it at? You just take the 1,000 divided by the hour, so 1,000 divided by 60 because we do time in minutes times whatever drip set we're using. So literally these are going to cancel each other out. So it becomes 1,000 drops a minute.
So for the purpose of testing, all of our drip questions are likely going to be just the fluid over time equation that we just worked on.
Fluid over this one, or like we just did with the dose. So, yeah, those are going to be those two are going to be the things that you're going to get quizzed on.
Okay, so fluid over time and then just dose.
Yep. Yes, sir.
Awesome. Thank you.
Any other questions about breaking medications down, concentrations, anything? I'll answer anything for you. And in the real world, are you probably going to use this math? No. But knowing how to do it, because you will get tested on it, it is kind of a must. And honestly, reminding yourself, because here's the thing, late in second semester, maybe even early second semester, third semester, you're not going to remember how to do this. So that's why taking notes is pretty vital, or keeping these worksheets is pretty vital. So that way you can look back on them, but having the steps laid out so that you can look back on it. And honestly, I'm not grading these worksheets based off of if you got them right or wrong. I'm basing it off of were you showing your work and trying to get it done, trying to figure it out. Because it's a lot easier for me to be like, you're on the right track, change this to that, than, okay, you got the right answer, but how the hell did you get that? Yeah, Anna, do you have a question?
Yeah, so with these worksheets and stuff, instead of scanning them all and sending them to you, are you going to be there Saturday for labs? Can we just bring them with us?
I will be there.
Awesome.
Yep. And you guys, I know a couple people have asked about like due dates and stuff like that. I changed the due dates. So even if the due date passes, I can still be like, okay, I can adjust the due date in Canvas. That's not a huge deal at all. If I say it's fine to hand me something in past the due date, then it's fine.
Thank you.
Yep. All right. Any other questions? Going once? Going twice? All right. Let's take like a 10-minute break, refresh your minds, and we're going to jump into our lecture.
Rudy, you said you had uploaded a new sheet for us yesterday.
Yeah, it should be, or I emailed it out to you guys. My apology.
Okay, because I think I submitted through Blackboard the old one.
And that's fine. And that's fine. And that's fine. But in this new one, I'm not grading it. It's just for you guys to have to work through and just keep like hang on to for notes.
Okay.
It's I know some people are going to struggle with the first one, so if they get this one done instead of the first one, I'll take that as well. But if you already did the first one, you can use this one just for practice.
Or you get feedback on the first one just because
Yep.
I'm pretty sure I was right on them. I just want to double check.
Yep. Yeah. It just takes me a little bit of time because I have to go through each question for everybody. But yeah, you will.
No, I get that.
Yep. I got you.
Okay, thanks.
Just 1 second here. I'm getting my thing set up for lecture. All right, so tonight we are getting our intro into pharmacology. There's not any meds we're going to cover or anything tonight. I actually saved that for next week. Next week, we're going to jump into our classifications. Tonight's going to be kind of the, almost, I hate to say the boring stuff, but it kind of is. But a lot of it, some of it is stuff you need to know, and I'll hit specifically at those slides. So if I say, hey, I'd probably write this down, or I'd probably remember this, there's a reason behind it. When we start getting to like the reasons that laws were created or the dates that laws were created, it's for that specific reason. Is that's information you probably need to know. All right, so when we administer a medication, we are looking to either correct an issue or honestly reverse an issue. You know, we can give fentanyl for pain management. You're going to hear me refer to fentanyl a lot because I'm going to use that as an example for a lot of these slides. Or if we need to reverse something, such as an opioid overdose, obviously we can use something like Narcan. The medications, some of them, especially when we start getting to like ACLS drugs, and ACLS drugs are used during cardiac arrest or severe cardiac conditions. Those are really going to be the drugs, in my opinion, where we're managing life-threatening conditions, where we're trying to raise somebody's blood pressure, or we're trying to speed up somebody's heart or slow their heart down. Most often, we're going to be giving pain meds. We're going to be giving medications to ease discomfort for the patient. So that could be something as simple as giving Zofran to somebody that's nauseous, giving Benadryl to somebody that has hives or is experiencing some sort of minor allergic reaction. Now, with us giving meds, we need to have the knowledge to know why we're giving it and know the consequences of the medication we're giving. You know, if we administer the wrong medication, if we administer a medication through the wrong route, if we give the incorrect dose, or if we fail to, deliver the medication at all. These are all mistakes that we can make that are going to have consequences. As a brand new medic, I gave a patient too much pain medication. I wouldn't say overdosed them, but if you ever heard the term snowed, I gave them too much. They went unconscious. They were still somewhat breathing and then kind of lost that respiratory drive as well. Well, instead of giving Narcan to reverse it, I said, okay, you know what? If I give Narcan, then I'm not going to be able to give any more fentanyl afterwards because Narcan is going to just not allow fentanyl to work. So I just essentially bagged them on the way to the hospital. They were perfectly fine. I knew that medication was going to be metabolized, but it's knowing what to do if you do make a mistake. So when we refer to pharmacology, pharmacology is the study of how medications or substances work with our body. What's truly going on? How is that medication honestly working? I don't expect you to do a deep dive into pharmacology, but I expect you to know what we're looking for when we give a med. What body reactions are we going to see? You know, I'm giving this medication to speed up their heart. I'm giving this medication to slow down their heart. I'm giving this medication for pain control. Knowing the classifications is kind of important. I gave you guys, or I put on Canvas your drug list, the cards you need to start to make. There's a lot of them. A lot of those you're not going to know after paramedic school, or you're going to forget. There's going to be a handful of medications, or you'll memorize the medications for your protocols. That's what I do. It's easy for me because I teach. I have to know all these medications, but when I worked full-time on an ambulance, I just memorized what we carried because that's all I needed to know at the time. But you also need to know what medications the patient takes. You go through their medication cabinet, you can start to build a history just based off their medication. If somebody's on, metoprolol, labetalol, I know that they probably have a problem with blood pressure. And again, that just comes with time. Some of this is going to come with time, so don't expect to know it this night or this second. So a lot of medications that we have are derived from plants or animals, and it has been for a while. Opium, it's derived from a plant. That's not going to be a synthetic drug then. That's going to be something that is natural. It's almost, like a remedy. Back in the day they had potions, they had like elixirs, if you will. Some of the medications, some of the things they had back then, we do still use today, absolutely. Even when we talk about like the Civil War or even Vietnam War, they used a lot of morphine back in the Civil War days. They used a lot of ketamine in Vietnam. We still use those to this day. Everything we do in regards to medication is backed by science, is backed by some sort of proof as to why we're doing it. We call that evidence-based practice or evidence-based guidelines. What that means is, okay, studies are showing this medication works great. Ketamine was a good example for that. For a long time, I didn't learn ketamine going through paramedic school just because it was foreign to us. It wasn't used pre-hospital. Studies started to show, hey, they use it in the ER, they get a really good response from it. And that's how ketamine was brought into the pre-hospital setting at that point. A medication just isn't approved. It's not somebody thinks of an idea and decides that they're just going to put a medication on the shelf. We saw what happened with COVID and how the COVID vaccine took this much time, and that was really streamlined. There's got to be extensive testing. There's got to be clinical trials done. Usually there's certain groups. One group will receive the medication, the other group might receive normal saline just to see if they have a placebo effect. And that's where they're also going to document, common side effects. I swear every side effect or every thing that we can see happen is going to include diarrhea, nausea, and vomiting. I would probably know this. The Food, Drug, and Cosmetic Act, 1938, what that did was established how medications had to be labeled. It established how medications were approved. It established how medications were taken away. And a lot of that was based off of evidence. So that's also when the FDA was formed, Food and Drug Administration. They do makeup, they do food, medications. They have to approve all that. And it has to have clinical trials proving that it has use before it can actually be used. Another date, it's not on there. We had what's called the Pure Food and Drug Act of 1906. Now, what that was, there's a reason medications have ingredients on them or food has ingredients on it, is because that said you have to label each ingredient that is in this. It took away mislabeling. It took away, false advertising. If you're going to advertise it for what it is, you need to explain the possible side effects of it as well. Now, anytime a medication is not used for its intended purpose, let's just say somebody uses Adderall for ADHD or attention deficit disorder or attention deficit hyperactive disorder, whatever. But somebody else takes the same medication, but they use it for, it speeds up metabolism. We're going to use it as a weight loss supplement. That's considered off-label because it is not approved by the FDA for that. That might be a side effect of it, but that's not its primary purpose. So that's when we say something is being used off-label, that's what we're referring to. It's not being used for what it's approved for. Now, this you will have to memorize. And I'm not saying every single thing on there, just the schedules. The Controlled Substances Act of 1970 set what was controlled and what was not. So this is actually in the process of potentially being repealed right now, just because a Schedule 1 is the highest controlled substance that there is. There are no medicinal purposes at all, highly addictive, illegal. Well, if you look at Schedule 1, that example there, it has marijuana listed. Marijuana has been proven to improve certain conditions. So they're actually trying to repeal this and have marijuana removed out of a Schedule 1 category. Schedule 2 is going to be still pretty high abuse potential. This is going to be your fentanyls, your morphines, codeine, cocaine, things that potentially do have a medical purpose. You know, back in the day, cocaine was used for severe nosebleeds. They'd use it in the ER to stop people's nose from bleeding. Methylphenidate, it's going to be the same as like Adderall. It is an amphetamine, technically. So yeah, these patients can become dependent on it, but there are medical reasons that this medication is used. Class 3, this is going to be like your Tylenol PMs, things with codeine in them, hydrocodone syrup, Vicodin. Pain meds, you're going to probably be prescribed by a physician at home, maybe post-surgery or you broke a limb or something like that. Those are generally going to be class 3. Class 4 is going to be more of our benzos, things we're going to use to control seizures, things we're going to use to control anxiety attacks. You'll notice as the classifications go down, there's a lesser potential of abuse. Class 5 being the last one, and that's just your over-the-counter cough medicines that have some sort of addictive, maybe some sort of narcotic in it as well. So Schedule 1, most dangerous, highest potential for abuse, no medical purposes. Schedule 5, over-the-counter cough medicines. Schedule 2, fentanyl, morphine, things we're generally going to give IV or that have a potentially highly addictive side effect. And then Schedule 3 is going to start to kind of taper off at that point. Ketamine is actually considered a Schedule 3. I'm not saying, again, memorize this tonight, but know what your schedules are of drugs. I'm not saying you need to know what exactly drugs fit in that category, but you should know Schedule 1, okay, no medical purposes, highly abused. Okay, Schedule 2, medical purposes, highly abused. Schedule 3, that's what I'm looking for in knowing which schedules of medications. I mentioned earlier, natural medications, derived from plants, derived from animals, minerals, even simple things like calcium that you can take home, mag sulfate. Those are natural hormones, as opposed to something being synthetic, where it is made completely in a lab. Fentanyl is technically synthetic. It's made in a lab. There are forms of fentanyl that are semi-synthetic. Part of it is natural, part of it is made in a lab. Now, each pharmaceutical company is going to control certain things of the medication, right? They're going to control the concentration. What that means is how many milligrams per ml, how many micrograms per ml are in this vial. The purity of the medication. Now, the FDA does have it set that it has to have a certain level of purity. What preservatives are in it to make it how long it's going to last. That's why that's why medications have an expiration date. If they had a massive amount of preservatives, they're going to last a lot longer. And then what other ingredients they're going to put in to make that medication? What are the components that are needed to make that medication? All meds will have a manufacturing date, a manufacturing lot number, and an expiration date. Generally, the manufacturing date only comes on the case, not the individual vials. The lot number and the expiration date comes on each individual vial. That's how we check to see if a med's expired, obviously. Forms, the meds are going to come in anything you can think of, but don't forget about, your pastes, like such as nitro paste, your transdermal patches. Maybe somebody has a pain management patch like fentanyl, suppositories, liquids, syrups, trying to think, any ocular medications, eye drops, any ear drops. Those are all different forms of medications, right? It might be in the same form, but they're used differently. Now, each medication is going to have 3 different names, technically. We might know it by 2 of them. I don't know meds by their chemical name. And their chemical name could be like 7-sulfur X betadine. Could be a chemical name. It's the chemicals that make up the composition of that medication. I don't know the chemical names. You're not expected to know chemical names. That's just what they're named in the laboratory. We have our generic name. So a good example of that would be ondansetron. Okay, the brand name for ondansetron is Zofran. So there's going to be two names that we're familiar with, ondansetron and Zofran. You should know both those when it comes to meds. I know that fentanyl goes by either A, fentanyl citrate, or sublimase, just because it has those two different names to them. Same with amiodarone. There's amiodarone and there's cortisone. Very similar, but again, one's going to be the generic name and one's going to be the brand name. Example they gave is furosemide Lasix. Now, people are going to take this at home and they might not know the name of the medication. So that's why it's kind of important for you to know what they do. Lasix, technically, we can give as paramedics. If I ask somebody, well, do you take Lasix? And they say no, but they say they take a water pill, they probably take Lasix. They just don't know what it's called. So know what your medications do and what other names they go by. Diphenhydramine, it's another name for Benadryl. There's multiple, and if you look at the vials of all these medications in your drug box, you're going to see the two different names. I wouldn't say each medication case generally is going to have almost like a little information pack in it, and it's going to talk. Think about when you get a prescription at the pharmacy. It has like these pages stapled to it. It's very much the same. It's going to tell you information about reliability of the medication. It's going to tell you about what the medication's used for, what the contraindications are, what the interactions are if it's mixed with another drug. It'll say the cost on it because that's what we pay or our insurance covers. But you'll also see an insert for the medication itself, which is going to tell you your dose, how you should be taking it, things you should be watching out for, or reasons you should not take it. A lot of times, a lot of this information is printed on the front of our pill bottles, right? It tells us how much to take and how to take it. Might not say what our contraindications are, but in a small print, it might say what we could expect to feel afterwards or what reactions we could essentially see due to taking the medication. Hospitals are mainly going to refer to what's called a physician's desk reference. And that's going to literally, it gets updated. I'm trying to look at the one on my bookshelf. The one I have is a 2001, and it's the 55th edition. So it's going to literally break down all sorts of medications, tell you everything about them, because we're not going to, we possibly cannot memorize every single medication. So there are means for people to have to look up meds as well. Hospital pharmacies are a great source of information, especially the hospitals you guys go to clinical time at. There's going to be pharmacists there. If you're in a large enough ER, they might have a pharmacist stationed in the ER, and they'll be able to tell you all sorts of information about the medication that they're using. Now, if you need to find additional information as a paramedic, don't use Wikipedia, but like RX List is a good option. You can download Hippocrates is an app you can download on your phone. It's a great app to be able to look up meds as well. And I still keep one of those apps on my phone just to look up patient medications to see why they take a medication, and it might tell me a little bit about their history. You guys shouldn't be too familiar with the American Heart Association yet, just like your CPR card. I understand that. But when we get into like ACLS and PALS, there's certain drugs in ACLS and PALS that AHA says there's strong evidence supporting the use behind it. A good example of it would be TPA or a clot buster. There is evidence behind showing if we administer a clot buster within this much time of somebody having a stroke, that the patient outcome is potentially going to be, or 70% more likely to be positive. That's going to have strong evidence behind it, as opposed to something having weak evidence. There's really no, either it's new or there's not enough information behind it yet to say if it has valid evidence behind it. And they might classify that as indeterminate because again, the evidence just doesn't exist yet. So they can't put a stamp to it. I don't expect you to know these classes. So far, I would know your schedules, your FDA Food Act, your Pure Food Drug Act. I would remember that stuff as up to this point. If you think of where you store your meds at your EMS service, fire department, wherever it might be, generally it's not near any windows. It's not near a door where somebody can easily get in. It's generally out of sight, out of mind, kind of locked up. Because there has to be a certain level of protection to our medications, but it's usually pretty convenient for you to get in and out of it. There's usually a key code, or maybe you keep medications in a vending machine. It's going to keep our medications secure so that we can get into it, but not the average Joe can. We try to keep them out of direct sunlight. Direct sunlight's going to tear down, it's going to start to decompose any medication that we have. Same with extreme temperatures. There's a reason why when the state of Iowa comes in and do an inspection, they want to know that your ambulance is kept in a climate controlled environment. And it's for this reason. It's for your medications. Now, some medications have to be kept at certain temperatures, hence why a lot of ambulances have fridges built into them, or we have a separate fridge in the ambulance with medications in them. Controlled substances are a different animal. For the state, for your service to carry controlled substances, you have to go through not just the state, but also the DEA and get a controlled substance license to be able to house those medications there. Your medical director has to sign off on it. Your medical director has to get a license for it. And what that means is that at least here, we have to have at least 2 forms of locks to keep controlled substances. I'm guessing your drug box might be locked up, maybe it's not, but I'm guessing your narcotics are, and they probably are in a container that has a lock on them, or like a zip tie lock or a tag number. That's technically a form of a lock. If your station is locked all the time, nobody can just walk in and take things. That's another form of a lock. Maybe, the door to your apparatus bay isn't out in the public view. That's another form of the lock. So there are additional measures besides just the drug box locking. Now, when we give a narc, a lot of times there are additional paperwork we have to fill out just because any sort of narcotics disposed or given has to be tracked pretty religiously. Maybe you gave 1 ml, but you wasted 1. That has to be written down and tracked somehow. And whether your service disposes of narcotics or turns them into a pharmacy really depends on your service. If for some reason, and I've been a part of a DEA inspection, it was a random audit, and it was probably one of the most terrifying things I think I've ever been through, because they want to track every single controlled substance you've given or wasted or received within the last 7 years. So as a service, you have to keep those records for at least 7 years and be able to look back and find specifically a certain medication that was given on a certain date. So that's why it's important that we log every single aspect of controlled substances. And again, they are the things that people are most likely targeting if they're going to steal a medication. They're not going to steal Benadryl. They're most likely going to steal fentanyl, morphine. And those are the things that are controlled the most, and for good reason. The term pharmacodynamics, that's when we alter some sort of bodily function by giving a medication. So a good example of that would be we take pain away by giving fentanyl. The pain is still there, but we've inserted some sort of medication to take it away. We've altered the normal process of the body at that point. That's what pharmacodynamics is. It refers to what's being altered within the body. Now, any med that we give can have toxic effects. Most of the time, it's going to be because we're giving too much, or we're giving the wrong med, or we're giving it the wrong route, or maybe the pump that you're using fails. There's a whole bunch of different reasons why a medication can have toxic effects. Most of the time, it's going to be because the wrong dose was given. So what happens in our body once you drop that fentanyl and give it through an IV? First thing that's going to happen is our body's going to absorb it. If you're giving it through an IV, IM injection, subcutaneous injection, sublingual, buccal, whatever it might be, the body has to absorb it first, and then it will distribute it to where it needs to go. So if it's fentanyl, it's going to be distributed to pain receptor sites. Once it reaches that site, it's going to undergo what's called biotransformation. And biotransformation is when the medication does what it's supposed to. It takes pain away. It raises blood sugar. And then our body is going to eliminate it. Most medications are going to be eliminated through the liver and the kidneys. Kidneys is going to be more often than not. So if somebody has problems with their kidneys, sometimes pain meds might not be the best thing for them because their body can't eliminate them. They're going to stay in their system a lot longer. Pharmacokinetics is how the body reacts to a medication. I give atropine, which causes an increased heart rate. I know that the pharmacokinetics of atropine are increased heart rate. That's literally what does this drug cause? Now, I wouldn't pay too much attention to this as far as chemical goes. I wouldn't even look at that, to be honest. It's nothing you're going to need to know. What it's referring to is how the chemicals are absorbed into the body in regards to your medication. Now, when we talk about receptor sites, this is something you do need to know, is how it binds with the receptor site. The easiest way I can say it is, as a kid, that game that you had like different shapes, and you had like a little table and you had to try to match the shape with the hole in the table. Like a triangle goes with a triangle, circle, circle, square, square. That's how our body reacts with medications. Those medications have to be built to fit in those perfectly portioned slots. So if I give fentanyl, it's going to work on a pain receptor site. And fentanyl is, let's just say, in the shape of a triangle. It's built like a triangle for a reason. It's going to fit perfectly in that receptor triangle site, as opposed to a medication being given for pain like Benadryl. Benadryl is not going to take a pain receptor site. It's not going to fit there. That's why it's not going to. That's why it's not going to take the pain away. Receptor sites are nothing more than a lock, and we just have to find the right key that goes with that lock. So anytime when we talk about two types of medications, there's agonist and there's antagonist. Think of antagonist as an anti-agonist, is how I say it. So an example of an agonist medication. Let's say I'm in pain. I give fentanyl. Fentanyl is an agonist because it is producing the effect of pain control, or it is producing the effect of reducing pain. It's doing what I want it to. It's filling those receptor sites. It's the key to that lock perfectly. An antagonist, a good example of that would be Narcan. Narcan does what? It goes in, it scoops out what's ever in that site. Narcan will then sit in that site to where you can no longer use it. That's why you can't give fentanyl or morphine after you give Narcan. You can, but it's not going to work on the patient. Agonist produces the effect we want. Antagonist takes away the effect. This, again, is probably the best way to put it. So if you look at the screen on the left, natural chemicals fit in the receptor sites perfectly. So when we give an agonist drug, such as fentanyl, that fentanyl has been designed to fit in those receptor sites to make the body think that it's a natural chemical. As opposed to the agonist or antagonist on the far right, those little brown, what Mario Brothers mushrooms is what they look like to me, are kicking out the drug and then taking the place. But now they're blocking it. So let's just say they kicked out fentanyl. Narcan just kicked out fentanyl and is going to sit in that receptor site now. That's an antagonist. When we talk about that fentanyl fitting perfectly in that receptor site, we're talking about affinity. And that's really how well does it fit in that receptor site. You go have a key copied. One of the first things you do when you have a key copied is you go check it in the lock. If it's too loose in the lock or too tight and not working, it's not going to work. It's the same. That's what affinity is. We're checking to make sure that it fits perfectly in that lock and does its job, that it binds with that receptor site the way that it should. Now, Our threshold is very much going to be like tolerance. How much medication is it going to take for us to hit our threshold? How much medication, what's the max threshold we can get of a medication before we start seeing adverse reactions, before the medication starts becoming potent to us? Potency is how much medication is required to get that to happen. So fentanyl, for me, the potency is going to be different than somebody that's half my size. It's going to take a lot more medication to reduce my pain than somebody that's smaller than me, just because I'm a lot bigger person. So the potency is going to be different. My pain threshold is going to be different. My tolerance to the medication is going to be different. And tolerance is going to be a whole lot on environmental factors, age. Elderly people can be on pain medications normally. So we might have to up the dose for them because that 25 micrograms or 50 micrograms of fentanyl probably isn't going to do anything for them. We have to find that little sweet spot when we're giving meds. How much do I give? And the good thing is it's in our protocols. My protocol for fentanyl, I can give 50 to 100. So your protocol might say it's weight-based. That's even better. It tells you exactly what to give. My protocol 50 to 100, I have either 50, 60, 75, 80. I have all these in between 100 that I can give. I just have to find what works for that patient. Again, antagonists are going to reverse whatever is in that receptor site. They're going to kick them out and they're going to take the place of the receptor site. These are reversal agents. There's only probably 5 or 6 that we're going to learn in paramedic school. The things that are reversal agents. The big one we know is Narcan. Narcan is technically what's called a competitive antagonist. What that means is that it competes for that site. As fentanyl's trying to get in, Narcan fights it off. It's competitive. Now, a non-competitive is just going to sit there in the site. This would be if I gave Narcan and then gave fentanyl afterwards, and the Narcan just kind of fell on the receptor site, let Narcan in, and let fentanyl in. It's not competing with it. As soon as something new is introduced, it will then move out of the site. It's non-competing. Now, just because we give a medication doesn't mean that it's going to change our cells themselves. It might not alter the function of the cell. And a good example of that is, let's think of somebody that's dehydrated. What happens in dehydration is their cells are kind of shrunk down. They don't have any fluid in them. All the fluid is on the outside of the cell, right? It's in the blood vessels. So we give normal saline to dehydrated patients, and normal saline contains salt. That salt goes into the cell. Water outside the cell follows the salt into the cell because water follows salt. We didn't change the cell. We just changed the nutrients that were going in and out of the cell. That's what they're talking about when we get into medications that alter receptors without messing with the cells at all. And mostly it's going to be fluids or water or like calcium, because that's a natural hormone. Mag sulfate's natural. Sodium bicarb is natural. Norepi is natural. Things that are natural to the body aren't gonna alter cells at all. And there's your sodium bicarb. Diuretics such as Lasix is gonna do the same thing. It's not altering the cell. All it's doing is making you pee a lot. It's making you get rid of fluid. It's not changing the cell at all. And anytime we refer to electrolytes, those are literally electrolytes. Read the back of a Gatorade bottle. It has vitamin A, it has vitamin B, it has calcium, it has all these different, forms of natural hormones within the body. That's what electrolyte-based medications are. Now, what factors affect how a body or how a person reacts to a med. Well, for one, it's what med are we using? There's a difference between ketamine and fentanyl and how the patient's going to react to it. Okay, the dosage. If I give somebody 25 micrograms of fentanyl, might take a little bit of the pain away. If I give somebody 150 micrograms of fentanyl, they're going to probably be unresponsive or pretty close. What route am I giving it by? IV and IO are going to be the fastest routes. It's going to be distributed the fastest versus giving an IM injection. It's going to take a little bit more time at that point. How am I giving it? Is it a fast push? Is it a slow push? Anytime you're giving any sort of med, the ones that I monitor the closest are the ones that can drop blood pressure and the ones that can stop breathing. And those are going to be our pain meds or our benzodiazepines for seizures. That's the instance where I don't monitor them with an automatic blood pressure cuff. I'll probably do a manual one because I know it can affect their blood pressure. And I want to know for sure that I don't have any changes in blood pressure I need to be worried about. We're going to primarily see weight-based in some pain medications, some drips, obviously, and then PEDS. Most everything PEDS is going to be weight-based. You know what's funny is the dose for kids of fentanyl is the same as adults, 1 microgram per kilogram. When it comes to your weight-based meds, I don't know all of my PEDS ones. I'll be honest. What can I use to find pediatric doses if I need to?
Braslo tape.
Bingo. It's going to tell me exactly how much I should give. A Braslo tape, also called a length-based resuscitation tape. I know my adult weight-based medications, such as pain management, just because I give them more frequently than I do PEDS. But it's a lot easier for me to give a weight-based. The math is already done for me. Hey, give 1 microgram per kilogram. The bad part is I have to guess the patient's weight. Most of the time, they're going to lie about their weight. And that's when you really got to assure them that you really don't give 2 hecks about what their weight is. You're doing it because you're giving them a medication, not because you want to, win a prize at the fair. Now, some of the other limitations is think of it this way: if I have somebody that's 500 pounds, I cannot give them realistically 250 micrograms of fentanyl. That'll kill them. So you have to use your best judgment in weight-based meds as well. You have to figure out their weight, and everything's gonna be in kilograms. You might as well just not even worry about pounds. That's why a lot of reporting softwares now, if maybe you write your report back your ambulance or whatever it might be, that's why it literally has a converter. If you can get the patient's weight in pounds and input it, it'll literally convert it to kilograms for you. Or you're literally looking at them in the case of an unresponsive patient. Maybe you're using weight-based RSI drugs, and you're guesstimating, they're about the same size as my partner. How much do you weigh? You're getting as close as you can in that instance. We don't have a scale, unfortunately. Now, what are some things that can affect how the medications are delivered? Obviously, if the patient is extremely hot, their metabolism is going to be increased. Their blood's going to be a little bit thinner. As to where if they're cold, their blood is going to be a lot thicker. The medication isn't going to travel as fast. Their organs are a lot slower because they're starting to get really cold. They're starting to shiver. Some certain genetic factors, and I'll be honest, I don't know these off the top of my head. But if I'm ever unsure, I'm guarantee your protocol book has it. Use caution with these patients. When you're making your drug cards, I bet there's certain drugs that says using caution with these patients. That's because we can see a side effect with certain disorders that the patient might have. If the patient is able to tell you, ask whoever you can that's near there. Neighbors, family, friends. Patients don't necessarily mean to lie when they tell you things, but you ask a patient, do you have any blood pressure issues? Nope, they tell you no. You look in their medicine cabinet and they have blood pressure medication. I'm not saying they're lying, but I'll usually confront them about it and be like, well, what do you take this for? Well, that's to control my blood pressure. And then that's when I get confused. And they're like, no, you asked if I have problems with my blood pressure. I don't, because I take that medication. So that's why some of your questions can be changed a little bit. Like, Have you ever had problems with blood pressure? Well, yeah. What did they do to fix it? Well, I'm on medication for it. That killed two birds with one stone. So be kind of crafty in how you ask questions. Medications in regards to pregnancy. There are going to be pregnancy categories and classifications in which the medication is going to affect the fetus or is not going to affect the fetus. We have A through X, and I don't mean all the way down through the alphabet, just A, B, C, D, X. A is going to be the most minimal medication we're going to give is going to have an effect on the fetus. So we're not going to really see any issues with that. If you see a class A medication, it's pretty damn safe. You see a class X, that means that it's going to pass through what we call the placental membrane and affect the kid. And a lot of times some pain meds can have class X categories. And again, that'll be on your, I'm not saying you're necessarily going to put that on your drug card, but when you're looking up certain medications, you'll see your pregnancy classifications. Now, some meds can pass through, again, like brain barrier, the blood-brain barrier, the blood placental barrier, and then the blood testes barrier. And what that means is that that medication is it'll pass through very permeable areas. It can be unsafe for those conditions. So if somebody has a head bleed, I'm probably not going to give this medication. If somebody's pregnant, I'm probably not going to give this medication because it has a classification against it. Or, if somebody has reproductive issues, I'm probably not going to give this medication. It's going to come down to very medication specific. I don't know those off the top of my head, and I didn't as a paramedic student either, and I don't expect you to. Now, please, I'm not trying to be mean when I say this. There are the patients that want medications that claim they're in pain, maybe, somebody that's like a drug seeker. We truly have no way to tell if they're just wanting pain meds or not. I mean, yeah, there's some clues. A good one for me is if the patient claims they're allergic to every other pain medication besides the ones that I carry, or the patient knows how much pain medication they should get, or if the patient has track marks. It's not my medication. I don't pay for it. I'm hired to do a job. I'll whatever. If you're in pain, I'm gonna give you pain meds. But I have had the patients that I go to start an IV, I flush the line, and they get a placebo effect just from that, and their pain will start to reduce. I'm not saying they weren't truly in pain, but I think the pain was more in their head than anything, to where they thought that saline was a drug and it was fixing them. That's what we call the placebo effect. Therapeutic effects are what you'll hear what's called the therapeutic index. This is how much medication do we need to give before the medication does its job. And this is going to be based on the patient's size, the patient's demographics, what potential injuries do they have. So think pain management wise, somebody with a stomach ache, I'm probably not gonna give a whole lot of pain meds to. Somebody that has their arm ripped off, I'm probably gonna give them a whole lot more pain meds. It's gonna change based off how much medication I'm giving them and what it's gonna take to be therapeutic for that person. Now, when it comes to pain meds, my dosing, I'd say a good rule of thumb for any meds, if you're gonna redose, is generally 3 to 5 minutes. If you need to repeat a dose of something or step up your next dose, give it 3 to 5 minutes before you're going to give your second dose or whatever it is at that point. If you give it too quick, the medication can just build on top of itself and then just have one big effect on the patient. If you wait too long, then you're essentially playing catch up with meds at that point. Now, anytime we give a med, we're looking for reactions, good or bad. Adverse effects are what we don't want to see happen with the patients. These are side effects that, again, we do not want to see. Now, I know if I give albuterol, a side effect that I'm going to see is an increased heart rate. If I give albuterol and the patient starts freaking out, that's an adverse effect. If I give, we'll say, calcium to a patient, and I notice they go unresponsive, that's not a side effect of it. That's an adverse reaction to the medication. Anytime you start to see any sort of adverse reaction, stop the medication for one, don't give it anymore. And now we have to figure out what's going on. Our therapeutic index. This is, again, think of how do I put this? There's a range where medication is going to work the best. And that's what we call our effective dose. 50 micrograms of fentanyl for this patient is probably going to be effective dose for them. If I overdose this patient, maybe 100 micrograms, that might get into the toxic dose where I'm giving just a little bit more than I should. Now, if I give this patient 400 micrograms of fentanyl, that's a lethal dose. The broader the index of medication has, the safer it is. The narrower the index, the more dangerous it can be for our patient, if that makes sense. So the larger the difference, larger the range, it's pretty safe. The smaller the range, the smaller the difference as far as therapeutic index, then I need to monitor that patient a little bit closer. And again, a lot of that can just come down to your dosage. If I give, my protocol say 50 to 100 of fentanyl, that's usually my effective dose. Anything outside of that, I'm going to start to get into my toxic and lethal at that point. Now, sometimes, and it's not necessarily an allergic reaction. I mean, it is, but the patient might not know that they're allergic to something, or their body doesn't know how to respond to the med, so it tries to fight it. And how our body tries to fight things is essentially we have an allergic reaction. It raises our temperature. It decides that it's going to open up our blood vessels. We're going to go into a form of shock. There are certain patients that you can see that in. Most of the time, they're going to know what those things are. That's why one of the first questions we should always ask if we think we're going to be giving a medication is, what are your allergies? Or I'll even ask them, hey, are you allergic to this? If it's something like epinephrine, nobody's allergic to epinephrine. It's a natural hormone in the body. If I have a patient that I'm going to give fentanyl to and they list off about 10 different pain meds, but they think they can have fentanyl, I'm going to give it, but I'm going to be very cautious. Or if somebody says they have an allergic reaction to something, I want to know how severe of an allergic reaction. Having a headache is different than, well, last time I felt like my throat was closing. They're having a headache, I can give them Benadryl on top of it. That's fine. Especially if they need the med. But if they have a severe allergic reaction to it, or they have had a severe allergic reaction to it, I'm withholding the medication at that point. The more medication I take over time, my tolerance is going to build. That's why you see some people that are addicted to drugs, their tolerance builds over time. They need more and more over time because their body has gotten used to a certain amount. If you've ever been on a medication and had to have your dosage changed, it's because your body got used to it, to where that dose was no longer effective. Your therapeutic index changed. Now, this will only happen with, if I take, I don't know, let's say I take 50 milligrams of Benadryl a day just to help me sleep. And I do that for a month. My body, for one, is going to become reliant on it. And I might have to continually up my dose after that because that 50 milligrams, my body has gotten used to. And I'm not getting any change at this point. So I have to continually up it. Why don't we take another 6 minutes? We'll do come back at 7:50. We've got roughly 30 slides left. So 6 minutes, we'll come back here and finish our slideshow. All right, let's wrap up this slideshow. The two classes that people are going to become most addicted to and become reliant on or dependent on is going to be stimulants and depressants. You might also have heard these as uppers and downers. So a stimulant would be like cocaine. It's going to get, that fight or flight system going. It's going to raise their heart rate. It's going to get them kind of worked up, raise their blood pressure. As opposed to a depressant or a downer, like heroin, which is going to suppress your body. That's why those people stop breathing if they overdose too much. That's why they're more relaxed. So there's going to be a difference between stimulants and depression. Stimulants are going to stimulate you to get kind of worked up. Depressants are going to kind of calm you down. That's why a lot of meds that people get addicted to is also benzos like Ativan or lorazepam, or that is Ativan. Trying to think the one that I can't remember off the top of my head, but anything for anxiety treatment most time is going to be pretty abused, or just simple pain meds. Now, that's why you'll see people that are on these medications long term become reliant on them, and then when they're taken away, they kind of, I don't want to say freak out a little bit, but their body isn't used to being away from it, and their body almost needs it, and that's when they start to go into like DTs or start to kind of withdraw from it at that point. Now, there are certain medications that interact with each other. I can't remember exactly, so don't quote me on this. I want to say it was like calcium chloride and maybe sodium bicarb. If those are given together, they'll do what's called a precipitation of the line, and it'll almost freeze the IV line because those meds they don't agree with each other. If I'm going to give a med right after another one, I don't draw the meds up into one vial or one syringe. If I'm going to give fentanyl and Zofran, I'm going to give my fentanyl, flush my line, then give my Zofran. That's fine. But I'm not drawing up fentanyl and then drawing up Zofran in the same syringe. If, I give too much fentanyl, or I give a dose of fentanyl and then I give Versed on top of it, they can be given together, but it's going to enhance the effect of maybe my patient's blood pressure dropping, or maybe my patient stop breathing, because those medications both do that as a side effect. So I just got to be careful of how medications are interacting with each other. Now, the second you give a med, their body will start breaking it down. If I give a small amount, the body's going to eliminate a little bit of it. If I give a large amount, the body's going to eliminate a lot of it. It's really going to depend on how it's given and what kind of shape the patient's in. Since a lot of meds are going to be filtered through the kidneys, if they have kidneys that aren't functioning correctly, then they're going to have a problem filtering. If they have a liver that's not doing its job, then they could have, if the medication is filtered through the liver, have problems getting rid of the medication through that organ. It's really just going to depend on the medication and the person's body. Maybe they have a fast metabolism. Children burn through medication because they are like on the go constantly. They have a very fast metabolism. Now, we have onset, peak, and duration. Onset is how long before this medication takes effect? How long before we get an onset of the medication? Peak is going to be the point at which we got the desired effect of the medication. We're giving fentanyl. That's when we have pain removal. The onset might be when the patient's like, oh, I'm feeling a little lightheaded. The pain, that I know that the medication is now working. As to where the peak is them going, yeah, my pains went down a whole lot. And then duration is how long is this medication going to last? And each medication will have different properties in regards to this. Not all meds can be delivered through all route. Versed, you can give IM, you can give IV. Even when we talk about endotracheal tube meds, which I think is the next slide, if I'm not mistaken, there were only like 5 or 6 meds back in the day that we used to give endotracheal. I'd never given a med through the ET tube, but there was only 5 or 6 that could be delivered through the ET tube. And the main reason for it was for patients before RSI was a thing for us, before we could sedate somebody, or before we could keep them down. You would literally, or before we had IOs, you would literally dump medications down the ET tube, followed by a flush down the ET tube. I'd like to think we're a little more sophisticated now, and we have different routes that we can administer medications. But Not all meds can be given IM. Not all meds can be given sub-Q. And your protocols will dictate that and how it should be given. If you were giving an endotracheal ET tube medication, it was like 2 to 10 times the dose. I don't carry that much medication. And again, it was only like 5 or 6. I think it was mainly our ACLS drugs for cardiac arrest. I don't carry that much medication. We've kind of gotten away from that, but it was there in case we couldn't get access on the patient. We could dump this down the ET tube. I love intranasal meds. I love intranasal pain medication when I can give it. Just be careful because pain meds, again, can drop blood pressure. But say I have somebody in their house before I get them out to their ambulance, maybe they, have a broken hip or whatever it might be. They're not in a position that I can start an IV on them. I can give intranasal fentanyl, but I want to get an IV as soon as I can afterwards because if their blood pressure starts to go down, I need to have a means of getting their pressure back up through fluid. So there are instances where intranasal meds are great, and pain meds intranasally is a great tool to have in your back pocket, to be honest. IV and IO are going to be our most preferred method. IV is going to be obviously the one that we use most often in the pre-hospital setting. You can see that in the emergency rooms. You technically can do what's called, an EJ, the external jugular in somebody's neck. Onset through IV and IO is going to be about the same. It's going to be very quick, very rapid, but remember the body starts limiting it at the point that as soon as you start giving it. I wouldn't even say there's a ton of limitations. I mean, yeah, if you don't get the IV, that's a limitation. Maybe this patient is a dialysis patient. There's a complication with their blood vessels. There's some of those limitations as far as getting an IV. But if you don't get the IV, that's probably the biggest limitation, I would say. IOs are our go-to, right? If we can't get access and we need a drug or we need fluid now, we go to the intraosseous access. Needle into the bone, it can be left into place for a little bit of time. Obviously, if there's any sort of bone decay or like osteoporosis, or if there's been an IO in the last 24 hours, we are not going to administer an IO in that site because we don't want to cause damage. An IO being placed isn't going to cause damage, but if it is repeatedly and there's any sort of disease processes the patient might have or any sort of injuries to that site, we might be doing them more harm than good. So fractured bones, amputations, things like that, replacements of knees, we got to be a little bit cautious if we're going to look at doing an IO. Most common ones we're going to be dealing with is our tibial site, our proximal tibia, or tibia tuberosity, or our humeral head, our proximal humerus. Now, sternum, you're going to see more towards military. You can, here's the thing is you've probably seen people come into the hospital, wherever. I always go for the spot 2 finger width down from my knee and 2 fingers towards the inside of my knee. There's a flat spot right there. But as long as you find a flat spot on the leg, even going down, you're probably fine drilling right there because you're going to have a blood vessel that runs through the bone. IM injections are okay. The main time I'm going to be doing IM injections is for, benzos or to calm patients down that are having anxiety attacks. Maybe I'm not able to get an IV on them or they're panicking or something like that. I can give an IM injection. IMs just take a little bit more time because they have to be absorbed through the muscle. Most common muscles we're going to be doing is either your deltoid, your gluteus, or right on the front of your thigh, kind of like like you would do with an EpiPen. Sub-Q, mainly what we're going to be doing with sub-Q injections. If you guys have ever heard of a medication called terbutaline or brethine, we use it for respiratory reasons. Also, you're going to be doing insulin injections, and a lot of insulin injections are going to be through the subcutaneous route, usually in the front of somebody's stomach, the anterior part of their abdomen. But on the back of your tricep, where you can kind of pinch skin, you can do that as well, or just right outside the belly button. You can pinch right there as well for a sub-Q injection. Those are going to be our 3 main spots. And they're not going to absorb like IO and IV routes. They're going to take a little bit of time. So if you're looking for an emergent drug, you might want to find something else because if that's the only route you have, it's going to take a little bit of time for it to be absorbed. I can't think of anything that we're gonna give besides nitro paste in the dermal or transdermal route. But you will see patients that have, again, fentanyl patches or some sort of medication patch or like a nicotine patch. Those are good examples of transdermal or dermal routes. There is sublingual. So we're used to nitroglycerin sublingual. Patient lifts up their tongue. We're able to put whatever it is, either whether it be a spray, whether it be a tablet under their tongue until it's dissolved. They say large doses are required. Yeah, because technically the amount of nitro we're giving in the mouth is a lot more than they should get. But we know that a lot of it's going to be distributed or filtered out immediately just based off the route. The most common inhaled or meds we're going to be thinking of, albuterol. Another one is Atrovent. If you guys have ever heard of a duoneb, that is literally albuterol and Atrovent mixed together. Epinephrine can also be nebulized into what's called racemic epi, and we're going to see that more for kids with like croup conditions. You can technically nebulize normal saline. You can nebulize anything that's a fluid technically. But inhaled is more going to be, a patient has an at-home inhaler and you're assisting them with it at that point. There's not a whole lot of meds that we're going to give rectally. The one I can think of is dextrose. If you have no means of getting access on a patient and you need to raise their blood sugar, some protocols will say that you can administer dextrose or sugar rectally, but again, that falls down to the protocols because some places don't allow it. Now, I'm not even going to say how the medication moves through the body. I'm just going to say how the body's affected by the medication is going to come down to the medication itself, is going to come down to the patient themselves, and is going to come down to what's going on with the patient. Again, environmental factors can play a role in this as well. Are they cold? Are they hot? Have they taken something prior to you giving their med? The first line of defense that we're going to see with anything that we do is it talks about barriers there. Your first barrier within the body is always going to be skin. I mean, if you think about it, we have to get through skin no matter what drug we give. IM, sub-Q, IO, IV, sublingual. The skin is the first line of defense for the body. If you've heard the term osmosis before, great. Osmosis is just the shifting of fluid. It's how fluid is able to move from one area to the next. Now, this could be like from the inside of our blood vessels to the inside of our cells or to the tissues. It's the movement of fluid across a membrane is what osmosis is. Again, when it comes to filters, kidneys and liver, those are what you need to remember as to what is filtering medications. Now, am I saying you need to know what organ is affected by what medication? No, just that your liver and kidneys are going to be most affected by some medications, especially if somebody takes a prolonged amount of medication. Those are the organs that are going to be hurt the most, or that you could potentially start to see organ damage. Goes back to what I was saying, epithelial cells are your continuous barrier. I don't care if it's, in somebody's nostrils, I don't care if it's in somebody's mouth, if it's their arm, whatever it is. Your skin is the first line of defense that must be breached before any medication can be given. It's just how our bodies are built. Now, some medications, and this goes back to what I was saying earlier in the slideshow, we have 3 different barriers: blood-brain barrier, blood-placental barrier, blood-testes barrier. We've got to be cautious if we're using this for other reasons, because there can be some side effects in regards to those areas. Again, somebody has, a traumatic brain injury. I need to know if the medication I'm going to give is going to pass through that blood-brain barrier. Somebody's pregnant. I need to know if that medication is going to pass through the blood-placental barrier. I need to know the classification and if that medication should be safe for my patient or not. It comes back to knowing your contraindications really more than anything. The only contraindications that I'm looking at when it comes to meds is I want to know what severe things am I going to see right now. Respiratory depression, hypotension, even when it comes to side effects. When you start your drug cards, I don't care if it causes nausea, vomiting. I want to know what side effects we can see that could potentially harm the patient. Now, I'm trying to figure out an easy way to say this without confusing you. Depending on what the medication is given for, if I'm giving fentanyl for pain, obviously it's going to take receptor sites. If I'm giving fentanyl for sedation, or maybe RSI prior to sedating somebody, it's going to spread in the body the same, but I'm going to have that leftover medication inside essentially the bloodstream that's distributed. Now, is it still going to act on the pain receptors? Yeah, it's going to take the place of the pain receptors because that's what it's built for. But it's also going to have other properties such as sedation, such as pre-medication for RSI. And most of that medication will just hang out in the plasma until it can find a receptor site to fill in for, until it finds that empty puzzle spot where it will fit in. Zero order elimination and first order elimination. When we talk about zero order, go back, sorry, my bad. I don't know how I did mess that up. All right, so zero order is essentially a fixed amount of medication that's going to be eliminated, and due to a certain period of time or due to a certain condition. As to where a first order elimination is going to directly correlate to how much medication is given. Remember, the more meds I give, the more is going to be eliminated. If I give a small amount of medication, a small amount is going to be eliminated. Zero order would be like zero tolerance. We don't care how much med you're giving, this much is getting eliminated no matter what. You probably never need to hear that again. You probably never need to memorize it or remember that at all. This you will need to know. Half-life. A half-life of a medication is essentially what it sounds like. How long until half of the medication is filtered or is eliminated? When we talk about half-life, so if I say fentanyl has a 5-minute half-life, that means half the dose that I'm giving is gone in 5 minutes. So that I know that duration can last up to, a good rule of thumb, we can just say 10 minutes, right? I know that that's the amount of time before I can start to see effects wear off. Kind of important, especially if you're giving a medication that you might need to bag a patient through. Also, how it's eliminated and how it's metabolized is going to be very dependent on the patient themselves. What is going on with them? What is their physical state? What disease processes do they have? Think of it this way. If somebody has severe trauma, losing a lot of blood carries medications. If I give a medication such as fentanyl, a lot of it might be wasted because the patient's bleeding out. It might not be distributed to the right places because the patient is bleeding out. Blood is literally a vessel for carrying everything for us, especially if you're using it IV or IO route. We try to give a dose based off the patient size. Again, larger patients, I'm going to give them a larger dose. Smaller patients, I'm going to give a smaller dose because their body is going to either burn through it or metabolize it differently. Peds burn through meds. A guy my size, I'm probably going to give a higher dose of a med too, just because my body is not going to eliminate it faster, but it's going to take more time for my body to use it. And in that time, it could eliminate a whole lot of it. I would 100% agree with this. The medications that I give, it comes back to memorizing things. I have my protocols memorized. Though now the medications that I do get kind of leery of is if I'm going to RSI somebody, I usually pull out the protocol book and verify at that point. But what they're saying here is know your meds inside and out, because in a stressful high, what am I thinking of? Maybe a really volatile situation or a bad car accident or something like that, your mind is only going to remember what you've done for a period of time. It's not going to remember things that you don't regularly train on. So what it's saying is to reduce medication errors, memorize and get in the habit of knowing what medications you're going to give and looking at the dosage and knowing what the dosage should be. Now, these are things that I do subconsciously. If you're going to get an order for a medication, especially if it's like you call the hospital and get an order, read back to them what they told you to give and how much of it. If I have a partner that, during whatever situation, hey, can you draw me up 50 micrograms of fentanyl? All right, I'll draw you at 50 mics of fent. I don't necessarily label syringes because if I need the med then, I don't want to take the time to sit there and label it. But I'll usually separate them or put where I know they're at, or I'll set the vial next to it so I know what that syringe is. If you're going to be transporting the patient and you think that their medications had something to do with what's going on, absolutely look at their meds. Or if you think your medication is going to interact with theirs, if you're not sure, bring them with you. Again, don't use Wikipedia to look up medication information. Probably not the best thing and I don't think in court Wikipedia is going to hold up. And I don't care if your partner's an EMT, whatever it might be, have them confirm the dose. They might not know the dose, but I am going to hold the med and say, okay, I drew up 2 mLs. Can you confirm 2 mLs? Yep. All right, we're good. They confirmed it for you. That way they go down with you. You guys are going to be cellmates together. Just some possible things that they list. That 4 milligrams could sound like 40 milligrams. 0.8 milligrams could sound like 8. Mag sulfate could sound like morphine sulfate. It's really that closed loop communication. So repeating back what is said to you, or using the people in your ambulance, using your partner. I don't care what level they are. Again, double check things with them. Have them double check your syringe. All right, this is the last part of the slideshow, and this is kind of, I wouldn't say difficult. I thought it was difficult to memorize, but everybody I told you so far treats me like I'm stupid. These are receptor sites or receptor types for our sympathetic system. Our body has 2 different systems. We have sympathetic and parasympathetic. Our sympathetic is what's also called our fight or flight. Our blood pressure is going to increase, our heart rate is going to increase, our pupils are going to dilate. Our parasympathetic is our rest and digest. We're watching TV, we're eating, we're calm, right? So within our sympathetic system, our fight or flight, we have these receptor types. So beta 1, if you look at the receptor label on the right, beta 1 refers to your heart. Alpha refers to your arteries. Beta 2 refers to your lungs. How I remember it is how it says right there. I know that alpha and artery both begin with A. So if I have a medication that's an alpha agonist, it's going to work on my arteries by constricting them or dilating them. If I have a medication that's a beta 1 agonist, it's going to increase my heart rate. I have 1 heart, beta 1. I have 2 lungs, beta 2. So albuterol is technically a beta 2 agonist because it opens up my lungs. Those are the only receptor types you ever need to memorize in paramedic school. Beta 1, beta 2, alpha. Alpha for artery, beta 1 for 1 heart, beta 2 for 2 lungs. Picture, if you're a picture person. So if I have a drug that's going to speed up my heart rate, it's a beta 1. Drug that is going to open up my lungs or affect my lungs, it's a beta 2. Drug that's going to affect my arteries or my blood vessels, it is an alpha. That kind of, does anybody lost on that? I literally don't know another way to say it.
I don't understand what you mean by the artery one, because there's a beta and an artery, or I mean a beta and an alpha on that one.
Alpha drugs only affect arteries, is what I'm saying. So like epinephrine is an alpha and a beta. Because if I give epi to somebody having an allergic reaction,
Yeah,
okay. They're having trouble breathing, epi's going to open up their lungs.
Right, okay.
Beta 2, yeah. So there are drugs that can have both of them, is what it's saying. But
Got
alpha is going to refer to only arteries. Don't pay attention to that beta on the artery. Well, that's referring to like epinephrine. Now, these next two slides are going to, I don't want to confuse anybody, so I was debating even going through them, but it's kind of pertinent. I can't put these ones off for next week. Your sympathetic system, fight or flight, right? Heart rate increases, we're kind of worked up, our adrenaline's dumping. Adrenaline is the natural hormone for the body in the sympathetic system. Kind of easy to remember, adrenaline rush. Anything that mimics the sympathetic system or a drug that is trying to get the sympathetic system going, such as epi, is called a sympathomimetic. How I remember that is mimetic and mimic. It mimics the sympathetic system. Kind of a mouthful. But remember, mimic, if you can remember mimetic and mimic, then it'll be easy for you. Parasympathetic and sympathetic are going to be the same, mimic or lytic. Now, there are sympatholytics instead of mimetic. Easy way I remember this is, what does a paralytic do to the body? Somebody.
Paralyzes.
Okay. So if I have a sympatholytic, it's going to paralyze my sympathetic system. Mimetic mimics, lytic freezes or paralyzes. That's literally how I remember it. Because I would even get confused if I didn't know that. Again, beta 1, beta 2, beta 1 referring to heart, beta 2 referring to lungs, alpha. You can have medications that do both, such as epinephrine, as you see in the bottom right there. Epinephrine has beta properties as well because it opens up the lungs. It increases the heart rate. It's adrenaline. Epinephrine is adrenaline. Sympatholytics is the opposite of my sympathomimetic. It's literally there to stop the system. So if that would be me giving a drug to stop an adrenaline rush because it's a lytic, it's a paralyzing the sympathetic system. I don't expect that to make 100% sense, and it won't. I just want you to know that if you're going to take a note, sympathomimetic mimics the sympathetic system. Sympatholytic paralyzes the sympathetic system. I would write that down because when we start getting to disease processes, that'll make a little bit more sense. And when you start to memorize and know what some of the drugs you're giving are, and you look at the classifications, it'll absolutely make sense as to what the drugs are doing. All right, that's enough head cramming for one night. We have a little bit less for the next week, a little more less slides than we covered this week. Next week is literally jumping into the classifications of meds. So we're literally going to start talking about meds. If you haven't even started your drug cards yet, this would be a good time to talk about and write about some of these drugs. And this is a great time if you have questions about drugs to bring them with you to class next week, because this literally it's nothing but drugs next week. It'd be a great time to answer any questions you guys have, or why we use something, or why your protocols say this or that. It'd be pretty beneficial for you. It takes a little while for this stuff to save to the cloud for me to be able to download it and post it online. Again, I'll put it on Canvas as soon as I can. On the homepage, if you just scroll down, it says YouTube, click watch on YouTube here next to the date to watch the recorded lectures. If you guys have questions, as always, shoot me an email, especially if you have questions over medications or anything like that. If you're, for you guys in Clinton, I don't get to see you guys, obviously, but if you guys ever have questions and I can, do a Zoom call or something with you guys, let me know, and I'll answer any questions that I can for you guys. Right now, if I don't respond to your emails right away, again, give me roughly 24, 48 hours to respond. I get so many emails a day, it's not even funny. I will get to them and I'll reply to them as quickly as I can. Otherwise, if you have questions, ask me. Otherwise, you can have a good night.
Thank you.
Rudy, on the drug cards.
Mhm. Yep.
I come across, say, like cardizem and deltiazem. Would
Yep.
that be two separate cards, or since they're the same between
Nope.
names, would that just be one card?
It's one card. Just you would just put
Okay.
like at the top deltiazem and and then cardizem in parentheses.
Okay, that's what I've been doing. I wanted to make sure that was accurate on that statement. Then.
Yep. Absolutely.
Thank you.